Hello and welcome to our presentation on how CareConnect and Spryfox use NLP in making patient-level decisions.
I'm Fiona Kiernan. I was a practicing doctor for 17 years and I'm also an economist and currently chief economist at CareConnect. And that's an Irish company where we deliver managed care for patients with chronic conditions. So patients with heart failure, with respiratory disease who are in the community. And to do that, we take data from multiple sources, including electronic health records, in order to be able to make those best practice decisions.
And I'm Debes. I have a background in artificial intelligence. I'm head of data analytics and AI at Spryfox. Spryfox is an AI consultancy located in Germany. We are experts in natural language processing and specifically focus on medical data, which includes electronic health records and documents. Together with CareConnect, we have a partnership since 2022.
So in terms of the project that we had and that we brought to Spryfox, our aim was to be able to make the best decisions, best clinical decisions in order to optimize patient care. But to do so, we needed to collect data from the entire patient journey. So from the moment they met their clinician right through to whether or not they were admitted to a hospital and what happened to them after that. And what we found was that often you get really valuable information, not unfortunately in the nice structured fields in electronic health records, but you often find the really good, useful information in the free text and also in the documents. But unfortunately, manual text extraction is just too labor intensive. So if we'd had a clinician or a nurse doing this work, that would have just been too inefficient.
Now, in order to automatically extract this valuable information from the free text and the documents, of course, we need a tool, an NLP tool that's focused on healthcare data. In order to find the optimal tool for us, we evaluated multiple of them and finally came to the conclusion that Johnson Labs was giving the best performance on this data. This was evaluated on multiple hospital discharge letters from real patients.
So the motivation for the piece of work that we're going to present to you today was that, regardless of how good a tool is, there's always the concern that it can fall below human performance. And as I said, you need to do potentially manual review. And in some cases, even if you're using NLP, you need to do a manual review, and that's still necessary. But unfortunately, clinicians just don't have the time really to review everything properly.
And one very important thing when it comes to evaluation of such NLP tools is that an evaluation purely on the entity level is not sufficient. For example, an evaluation on how accurate a drug name is detected. What we actually need is an evaluation on a patient level. So taking the full patient data and seeing how good the quality on this entity extraction is. In addition to that, what we need is also continuous quality assurance so that we get better and better over time. So what we are proposing in here in this presentation also today is that we are building a framework around Johnson Labs to assure ourselves of the quality that's allowing us to label quality information, allowing us to label the entities that are extracted, review them, and by that assuring ourselves of the quality provided.
So this is the type of document that we might see. So we've taken some of the information off here, and actually this is a fake hospital discharge that we've just created for the example. But you can see that there's really useful information in this in terms of the background medical history of the supposed patient, but also in terms of their medication much lower down. So this is something that we would really want to get good quality information from this document.
And this type of hospital discharge letter now would go through the first technical step, which is the OCR, of course, which extracts the text information out of that document.
But the reality is, of course, and again, these are fake hospital discharge letters. The reality is that this is what they tend to look like. They're never the nice kind of example that we had on the previous page. So you can see over here on the left-hand side, we've got some spelling mistakes, and down on the right, we've got a table.
Why is this important? Let's start with the left-hand side, where you can see the first sentence, medications on discharge, bisoprolol 5 milligram, etc. One of the problems, besides the spelling mistake, is that we have multiple medications listed within one sentence. So we have the bisoprolol with the 5 milligrams taken once a day, etc., all in one sentence without a clear structure in between. We're using the relation detector from Johnson Labs in order to associate a dosage to the drug name. For example, in this case, the 5 milligram to the bisoprolol. But of course, depending on how this sentence is written, this can be tricky and sometimes prone to mistakes also. On the right-hand side, we see that in a lot of cases, the medication is actually provided in a tabular form, having, for example, the medication name on the left-hand side, and then followed by the dosage and also followed by the frequency, which is why we're using the respective models from Johnson also in order to extract data out of tabular formats. How did we now build the workflow? The very first thing is we went to the whiteboard. On the technical side, we listed all of the elements that are needed in order to, on the one hand, connect to the EMR system, extract the entities, a quality labeling, then reviewing the data, up to finally the extracted quality information.
And what I thought about was really, how do I behave in the normal sense in terms of a clinic or a hospital? So if a patient turns up and they have their letter, how do I ensure that that letter belongs to a certain electronic health record or belongs to a certain medical record? What are the steps that I would tend to go through as a human, as a clinician, in order to ensure that, or to assure myself that this is the correct information?
Let's go now in detail through the workflow. On the very left side, we have the document extraction. So we connect to our electronic medical record system to extract, for example, the PDF or whatever file format the hospital discharge letter is saved as. Our next step is the entity extraction with TransKnowLab. There's an OCR beforehand, and then we're extracting the entities, which in our case for our application are the patient name, the date of birth, admission date, medication, as well as conditions. The next step then is the quality labeling. That's the important part that we would like to present in this presentation also, in which we are labeling every entity that came out, for example, a drug name out of the entity extraction, with relevant quality assessment information. I'm providing details on that one later. These quality labels allow us to do a review planning. So you can imagine that there are certain entities that are extracted, but that violate quality rules. Imagine, for example, that there's missing information. Based on this, a review planning can be done, and on the lower part that you see, an entity review by a clinician can be planned. So any entities that violated specific quality rules can then still be reviewed by a clinician. On the upper part, we have the document review part, in which we are looking at the documents that passed all the quality checks. So we are from the quality labeling side, fine with the chunks and the documents, but we are still giving a small subset of that as a control to be reviewed by a clinician. Why do we do this? The reason for that is that we also are aware of the false negatives, so the things that we otherwise wouldn't see. The final part of this workflow is then that, of course, there's the correction of the entities in there, which means that a clinician can review the entities that violated certain quality rules. This can include a correction of spelling. It can be adding new entities or correcting existing entities or confusion between entities. A review status then can be changed, which might be either that the review is completed, for example, if a spelling mistake was detected, or in some cases, a second opinion might also be needed. And finally, we have the very important part, which is our changelog, which is keeping the difference between the original annotations or the original detections of the entities and the changelog as done by the review by the clinician. For two reasons. Number one is that we have this documented for a possible audit. Number two, that we can change parameters. So this whole workflow that you see here is not one that would run through once only, but there's a whole feedback loop in which afterwards we can adapt certain parameters. For example, there are confidence thresholds that we set in the beginning that we then, after this changelog, adapt over time and get better and better. Let's now go in details into the quality rules that we have established. In order to do that, we are first focusing on medication only. There are 4 quality rules that we have established for medication. The very first one has to do with the confidence level. Once the entity extraction is done by TransKnowLab, for example, on a drug name, we always have a confidence level associated with that. And it's quite intuitive that if this confidence level is low, so if the algorithm, the NLP algorithm, is uncertain about whether this is really a drug name or not, this is something that should go to the clinician review. So the first one is the confidence level, and in our first iteration, we found that the threshold of 60% is a good one to automatically flag entities for review. The second one has to do with the drug names, doses, and frequencies. It can sometimes happen that the machine learning algorithm detects drugs that aren't known in national formularies. This is something that can happen, and of course, this is something that needs to be flagged if there is a drug detected that actually doesn't exist in national formularies. Similar thing can also happen with the dosage and the frequencies so that they don't fit with a drug name. An example is given on the right side where we have the drug name detected as paracetamol, And dosages are required to be within the range of known dosages for paracetamol. So, for example, if in this case a dosage of 5,000 milligram would be detected, this would also be flagged for review. For the third part, it's important to note or to repeat that we don't only have access to the documents, but we also have access to the whole patient history in the EMR. So one thing that we can easily do is to see if this detected drug in the entity actually matches or appears in the patient history. If it does, this is correct with a higher probability. If it's a new drug that the patient has never been taken before, this is something that can be flagged for review. And the final one is a more obvious one, let's say. These are missing fields. So for a drug, we have the drug name, the dosage, and the frequency, and or other parameters such as form and duration. And it can happen that only some of these fields are found in the entity extraction. It depends then in the end how we decide those rules. In our case, what we said is the dosage as well as the drug name and the frequency have to be present. These three have to be present, whereas we don't get too concerned about, let's say, a missing form or duration. How does this look like in practice? We have one extracted drug on the left-hand side, furosemide, to be taken daily with 40 milligrams of strength. This is the extracted entity, and we can see on the right side that there are three quality labels where we have a check mark, it's passed. The drug is associated to both the strength and the frequency. So the relation detector that we use by John Snow Labs found for furosemide linked it with a daily to be taken daily and a strength of 40 milligrams. The named entity recognition confidence for that name furosemide is above 60%. And also the strength and the frequency are within the expected range. So furosemide to be taken daily at 40 milligrams is something that is clinically valid. Now let's come to our overall results. We evaluated our frameworks on 144 documents. Those are real hospital discharge letters from real patients. In 131 of them, there was at least one drug detected, and we have a total of more than 1,300 drugs detected across all documents. Two interesting numbers on that one. The first one is that in 23% of the cases, the detected drug did not appear in the patient record before, which is perfectly defined, so it's a drug that is new to this patient. The other number that's important is that in 44% of the cases, the detected drugs were not associated with neither frequency or the strength by the relation detector. What is very important to notice that this is not a problem of the NLP method, but simply about how the text is written in the documents. One example is given on the lower part. So we have the sentence, Mr. Mertz was admitted to A&E on the 17th of February 2018 following allergic reaction to Augmentin. Augmentin is, of course, detected as a drug name, perfectly fine, but the sentence simply doesn't provide a strength or frequency.
In the cases then that I did review, we found that in 9% of cases, the drug had to be added or corrected. So in the majority of cases, it was just that the drug was missing. It wasn't that there was a problem or an inaccuracy. In 5% of cases, though, the drug name was there, it was present and correct, but the dose was either missing or incorrect. So in each of those cases, we corrected them, and the idea is that they go into further iteration than later. So, I mean, what we would say, I guess, at the end of the work that we did was that we were really satisfied that this is a high quality healthcare NLP tool. But whenever you're using something in terms of day-to-day clinical practice, or even if you're using it in terms of maybe making a commercial decision as well, it's not enough just to know that it's good quality. We also had to be sure that we're following particular steps and that we could assure ourselves of the quality of the work that we were doing.
What we believe are the benefits of our approach are the following three. On the one hand, we believe that we map the understanding of how a clinician thinks about patient information into this workflow. Second, it has been a collaborative approach. So it's using the clinical approach to quality assurance as well as the technical or AI side of it. And we found that the idea of the feedback loop, in which after each iteration we can tune parameters, proved to be extremely helpful. But still, there are, of course, many areas for improvement. Number one, with this framework, we reduce the review time necessary by a clinician. But of course, this is something that we still want to reduce further, especially when it comes to the random control sample. Second, we observed that simply in the way how physicians prescribe between different hospitals or between different physicians also, there are many inconsistencies, and we need methods to correct for that. And as a third one, we showed you the application of that framework today on medication data, but of course we want to extend this now to conditions and dates also.
So thanks a million for your attention, and we look forward to taking your questions.